Hi, my name is Rachael Harris, and this is my geriatric syndrome case study PowerPoint on falls. Falls is a very common geriatric syndrome. So a fall is defined as an unpleasant descent to the floor with or without injury. Falls can occur because of many different causes. So influential factors could be a history of falling, weakness, an unsteady gait, functional decline, vision hearing deficits, or it could be related to their drugs that they take. Environmental causes can be a slippery or uneven floor, bad lighting, improper shoes, pets, throw rugs, etc. Falls are common and they do cause morbidity and mortality in our older adult patients. An estimated 1/3 of older adults will fall, 10% will sustain some type of injury. Long-term care increases your risk for falls, and about 2% of injury does occur during hospitalization. The risk of falling increases with age. 50% of individuals over the age of 80 will fall at some point during their life. JH is a patient I've seen in clinical. She's a 74-year-old female that came to the clinic after nursing home discharge. She was sent to the nursing home after hospitalization when she fell, and it resulted in a left orbital floor blowout fracture and a right knee injury. Her past medical history includes CHF, hypertension, AFib, moderate aortic regurgitation, high cholesterol, COPD, gout, chronic kidney disease, anemia, liver mass, and nearsightedness. She's closely followed by cardiology and pulmonology. Past surgical history includes EGD, colonoscopies, and a liver biopsy. She's been hospitalized twice. The last hospitalization prior to the fall was in July when she was anemic. She has a lifetime history of 4 units of PAC cells, and she denies any tobacco, alcohol, or drug use. Past cigarette smoker, she's been quit for 5 years. This slide continues subjective patient data. So JH denied any food, drug, or environmental allergies. Her health maintenance is currently up to date. She's had all required vaccines, colonoscopies, stool testing, mammogram, and she has regular dentist and vision visits. And she visits the clinic to see the nurse practitioner I'm with every 3 months. On the bottom there, I just put a recommendation from the USPSTF. They do recommend for her case would be a DEXA scan and a low-dose CT scan. She does have a history of a 30-pack year smoking history, and that's why the recommendation is a CT scan to rule out lung cancer. She has had recent chest x-rays that have not shown any abnormalities. There was not a DEXA scan on file for her, which would be beneficial given her recent fall, just to make sure there's no osteopenia or osteoporosis. On this slide is the medication she currently takes. So she takes Eliquis twice a day for atrial fibrillation, furosemide every 3 days for congestive heart failure, losartan daily for hypertension, Norvasc daily for hypertension, her allopurinol daily for the gout, and Symbicort and albuterol for the COPD. She does report an increase in the use of her albuterol inhaler, so before she was using about 1 to 2 times per week. For the past 2 weeks, she has noticed she's been having to use it daily because of shortness of breath with exertion. She says her symptoms are quickly relieved after the use of her inhaler, but she has had an increase. Also, she was put on oxygen by her pulmonologist in October, and she wears that at 2 liters continuously. Pertinent positives on the review of systems included the reporting of shortness of breath and the right aching knee pain. She has occasional bilateral ankle edema, which is unchanged and is normal for her. It has not worsened. Pertinent negatives include denies any vision changes, orbital edema, facial pain, chest pain, palpitations, syncope, blood pressure irregularities, cough, muscle weakness, gait changes, skin changes or rashes, headaches, numbness, weakness, changes to consciousness, or forgetfulness. This is how a patient may present to the clinic if they had a fall. They may report a slip, trip, near fall, or fall. They may report someone caught them before they hit the floor. They may state why they fell. Passing out, seizures, they trip over something. You want to know where they were standing when they fell. Were they on the ground level? Were they on a stepping stool, retaining wall, ladder? The next important thing is to know, was an injury sustained? Small injuries may not be reported. You want to know if there was any pain, swelling, skin changes, or deformities after a fall, and try to find out if any injury was sustained, no matter how big or small. Patients who fell and were down for an extended period of time should be assessed for dehydration, pressure ulcer formation, and even rhabdo. This is the beginning of objective data. Her vitals were 98.2, 86, 18, 117/76, and 98% on 2 liters by nasal cannula. She was in no distress. She was alert, well-nourished, and dressed appropriately. Her eyes were symmetrical. Pupils were equal, round, and reactive to the light. EOMs intact. Red light reflex, known as nystagmus, sclera white, conjunctiva pink and moist. She had an irregular heart rhythm related to atrial fibrillation. She has a grade 3/4 systolic heart murmur. Her radial and dorsalis pedis pulses were 2+ without peripheral edema. Respiratory system, her chest had equal symmetrical chest expansion. Her lung fields were resonant upon percussion. Clear breath sounds bilaterally without adventitious breath sounds. Tactile firmitis was normal and negative for bronchophony and egophony. She had normal skin color and turgor. There was no lesions or rashes. She has normal nail bed color without cyanosis, and there was no obvious bruising. She has normal strength in all 4 extremities, full range of motion. Range of motion in the right leg was equal to the left, despite the knee injury, and there was no redness, swelling to that right knee joint, and she had a normal patellar reflex on bilateral legs. Neurological, she's alert and oriented ×4, intact memory, cognition. She exhibits clear, coherent speech and displays emotions appropriately. The first screening tool is the COTS index for ADLs. She scored a 4 out of 6. 2 points were deducted because she did require minimum to moderate assistance with bathing and dressing, and this was because of her respiratory status and becoming short of breath with activity. The second screening tool was the Instrumental Activities of Daily Living scale, or the IADLs. She scored a 4 out of 8, and this was because of the inability for her to go out and shop on her own. Her niece helps prepare meals and does most of the household cleaning. She's limited to minimal household cleaning. She does her laundry. However, she has no issues with using the telephone, managing her medications, and handling finances. The third screening tool is the Tonetti Balance Assessment. Her total score was a 20 out of 28. More points were deducted for her with balance. Points for balance were deducted because of the use of the chair arms when standing and sitting. Immediate standing balance was steady, but with the use of a walker, she swayed when nudged, and she was unsteady with her eyes closed. For gait, she had a slight deviation when she walked down the hallway, and also that wide gait deducted points. The fourth one was directed towards her niece, and it's the Caregiver Strain Index. Her score was a 3 out of 13. A score greater than 7 indicates a high level of stress. She scored a 3 because caring for her aunt has been inconvenient at times. She's had to change personal plans. She doesn't like leaving her at home alone because she's afraid she'll fall and she'll be without assistance for a long period of time. Final diagnoses for this office visit include atrial fibrillation, pain in unspecified knee, shortness of breath, and unspecified fall. Based on her shortness of breath, this could be attributed to COPD, congestive heart failure, or anemia, given her history. Her COPD has worsened, which resulted in her having to go on O2 continuously this past October. Congestive heart failure is something she hasn't had an issue with in the past. Her lung sounds today were clear. She was without any weight changes, and she denied any new or worsening cough. She also does not have any weakness or fatigue. Anemia has been a problem. Her last hemoglobin and hematocrit were normal. In the past, her main presenting symptoms has been shortness of breath, so ruling that one out would be priority. Her follow-up schedule is in 1 month after she sees cardiology and pulmonology to assess their treatment plan. For her, a CBC was ordered to look at hemoglobin and hematocrit to rule out anemia. We also wanted to do a CMP to look at kidney function, liver function, and electrolytes. A recent knee x-ray and an MRI did not show any acute findings, so it's suspected that it's just arthritic pain that's worsened because of the injury. She was ordered diclofenac topical cream to apply 4 times a day. NSAIDs are not favored for her because of the bleeding risk, so this will lessen systemic effects. Workup for fall patients would include finding the cause of the fall so that future falls can be prevented. You want to know if the cause of a fall was an acute illness or a chronic problem. Was it related to an unsafe environment? For example, she had got her foot caught on a coffee table. It caused her to fall. And you also want to look at medicines and polypharmacy to see if that is the reason for the fall. Here are community resources for falls. The first one is Myths of Older Adults and Falls. Knowing fall myths prevents falls. Some common myths may be falling is something normal for my age. If I limit my activity, I won't fall. Falling happens to other people, but not me. There's also a map of partners and programs which provides community-based fall prevention programs in your area. There's fall proofing your home, fall prevention conversation guides for caregivers. There's evidence-based fall prevention programs. Here's an exercise and physical activity guide. It's a 120-page guide of the benefits of physical activity in older adults and how that physical activity improves your fall risk. The Elder Care Locator, and then the last one is an assistive technology program that provides information on how to obtain grab bars, ramps, and motion-activated lights to improve the safety of your home. Here are 4 areas to discuss when it comes to falls. The first is health behaviors. So my patient had attempted to create a safe home environment. She had no throw rugs, no small pets. She has grab bars in the bathroom. She watches her oxygen tubing when walking, and she also ambulates with a walker. Social determinants are important because if you have a family or support system, they are more likely to make you seek treatment after a fall. Socioeconomic issues are important. Insurance and access to healthcare could impact a person's ability to seek treatment. And you can see there the expenses of falls is very outrageous. Legal and ethical issues. To avoid legal action, you want to closely monitor your patients with accurate follow-up appointments. Most medications prescribed to older adults will have negative side effects. You do prescribe a new medicine, follow up soon to ensure no negative side effects are occurring. A big thing I learned during this assignment and in my clinical experience is the importance of discussing falls with your patients before a fall occurs. So I've learned the importance of fall prevention. Falls can be very complicated geriatric syndrome because the cause can come from many different things. Investigating the cause of a fall is essential to a future fall prevention. Being thorough in history taking in your physical exam can discover if any injury has occurred if the patient has fallen. Also, in my clinical experience, I've noticed there are several patients that still had throw rugs, inadequate lighting, and no access to grab bars in their home. While acute illness, chronic disease, and medications can cause falls, at least ensuring the patient has a safe home environment can be one step to ensuring falls are prevented.